happening here?
So there's a liver shadow, which is obviously obvious, and then there's a gas. There's a gas shadow, whether it's biliary or I think it's not biliary. It's outlining the liver. This shadow.
Okay. This thing is something which is a point of discussion. But if you see these loops of bowel,
yeah, they're dilated and gas filled.
See anything here? Here.
There's basically I can describe this film. It's a abdominal film which is showing dilated loop bowels with the gas in the wall of the bowel, pneumatosis, and then probably the gas in the portal venous system, which is
conclusion.
Conclusion is ischemic bowel with portal venous gas.
Excellent. So here, okay, thank you. Number 6. Number 7 is next. Please be ready. If you see here, there is gas within the wall of the bowel, and these are dilated loops, so must be paralytic. And with that, there is what we call gas in the portal vein, Pneumatosis intestinalis. And one of very interesting ones, you see, benign causes, 12 patient versus life-threatening cause. One thing which I want to warn you is this one, idiopathic. Idiopathic pneumatosis intestinalis is a very important exam case. I don't know how many of you have seen it in your clinical practice. We have got 2-3 very good cases in our hospital which come every few years. And these patients will have bubbles of air in their small or large bowel within the wall. They've got a pathognomic radiological findings. And if you see it once, you are never going to miss it. If you don't know it, you are never going to pick it up. What happens is that these bubbles of idiopathic means we don't know what has happened. And these bubbles, they might burst, and these patients might come to the hospital with pneumoperitoneum. But this pneumoperitoneum is what we call pneumoperitoneum without any peritonitis. So you have to understand this. So this is a very important exam case. Gas in the portal vein has got a differential, which is here. All of you know this, infarction, etc. So this is a case of gas in the biliary system. And gas in the biliary system is nothing important. You know, gas in the portal vein is very important, but gas in the biliary system is not all that important, because one of the usual cause is incompetent sphincter, which can happen in old age. 7, are you with us? Can you raise your hand? So, can you hear us?
Yes.
So, in this case, there is ischemic bowel. Because of time factor, I want to crack on. You tell us the findings.
Okay, so there is small bowel obstruction with dilated loops of centrally placed bowel, and there is some gas within some shadows within the projected over the liver, in keeping with portal venous gas. And there are some on the left-hand side. There's also some air between bowel loops, so likely to be some pneumatosis as well.
Right. So if you see here, this, if you trace this, you can see a bit of air within the wall. When it is projecting tangential to the beam, you will see it much better. Now, if you look carefully with this finding, there is a bit of regular sign here. You can see the serosal surface. So this is a regular sign. When they will show you ischemic bowel, like this on a plain film, keep looking for signs of pneumoperitoneum. when there is ischemic, when there is ischemic bowel, there will be obstruction and functional obstruction, and with that, there can be pneumoperitoneum. Well done. Just name this finding. What is happening?
So it's a gastric volvulus.
So where is this air?
Yeah. Oh. No. So there's air around a dilated hyperdense structure in the...
That is the stomach, you were right.
Yeah, stomach.
The point is that where is this air?
So the air must be peritoneal.
Can it be within the wall?
It could be. So that could be a pneumatosis of the stomach.
Yes. Now, what is the concept? The concept is that, by the way, this is a contrast examination. Part of the contrast has gone, there is a bit of gastric outlet obstruction. So the concept is that when there can be sort of obstruction or dilatation, sometimes what happens is that to develop your concepts, basically think like this, that pressure, intraluminal pressure has increased, and there is a rent or in the mucosa, and air goes inside. When air goes inside, it will go into the wall. So secondary to any kinds of obstructions, you can get a bit of pneumatosis. So this is a case of pyloric stenosis, which has presented like this. This is a slam dunk case. What is your diagnosis here? Around the stomach, what is happening?
So there's pneumatosis within the stomach.
Right.
Wall. There's also small bowel obstruction, and there's portal venous gas as well.
Excellent.
So
conclusion?
So it's bowel obstruction secondary to with small bowel ischemia, pneumatosis.
Are there any signs of small bowel ischemia visible to you?
Actually, no, the small bowel loops are all enhancing normally. Right. So pneumatosis secondary to small bowel obstruction.
Right. So this concept is similar to the one which I was showing you in the previous film. This patient was very interesting. This patient came to our A&E and actually walked into the A&E with chest pain. And they asked for a CT, and then we picked up something, dissection and things like that. And we then did the abdomen. The point I'm making here is that this patient actually had small bowel obstruction. There were no signs of ischemia. You have to pertinent negative or positives in the exam. I will come back to this when we will do small bowel. Regarding ischemia, what should be your pertinent negative and positive? I'm not showing you everything here. This patient had obstruction. And with that, you can see this, the string of bird or string of pearl sign. And because of that, the gas, the same hypothesis has gone into the wall, actually has also gone into the wall of the stomach. And this patient was clinically quite well and radiologically speaking very bad. Ultimately, did surgery. Irony is that the patient developed some complications, and I think 3 weeks down the road, he died. So in any case, this is another mechanism of gas going into the wall of the viscera. Okay, this is the Aunt Minnie case which I was talking about. Over to you.
Okay, this is a coned-in abdominal radiograph. There's a dilated loop of bowel with multiple locules of gas within the bowel lumen. and there's some locules of gas also near the inferior portion of the film that seem to be sort of, just projecting from the bowel wall.
Right. So what thing is this?
So could be multiple diverticuli?
Okay, if you look carefully, diverticuli will not look like this. You know, these are unknown. These are grape-like, bubble of airs, bubbles, multiple air bubbles, which diverticuli will never project like this, particularly on a plain film. And the key thing is that some of them, when you see tangentially, they are projecting outside. Now, if you see this contrast examination, it will tell you what is happening. These are multiple air bubbles. Now, develop your eyes on the finding here. Tangentially, you can see that there is an air bubble here, and look at them. They are projecting beyond the wall. So this is what I call, the idiopathic or primary pneumatosis intestinalis. You remember this differential diagnosis? Idiopathic, benign causes. And idiopathic also tells you that we don't know the etiology. And please develop your eyes on this. And I've got a very good case on CT also, these ones. But of course, for that, you need a software, a DICOM viewer to pick it up. And so remember this. And when these air bubbles will burst, the patient might develop pneumoperitoneum without any peritonitis. So we use that word pneumoperitoneum without peritonitis. The patient will be absolutely fine. So this is idiopathic pneumatosis intestinalis. Classical 2B film. I've been very kind as an examiner to give you this history. But because of time factor, I have given you this history. But this is a classical, very good 2B film. Over to you.
So in the epigastrium, there are multiple gas locules, and there seems to be one large, sort of well-defined lesion bordering them. And these are in just below the rib cage, so it's at the level of the pancreas. There's no evidence of bowel obstruction. So these features, the differential for this could be a large pancreatic pseudocyst.
Right. If you see here, this is the stomach. This is the transverse colon. There is gas here. Look at this bubbly type of an appearance. With this history, what else can it be? On a CT, what do you think?
Oh, so it looks like pneumatosis.
No, where is it? Anatomy-wise, if you see, this is the stomach. Behind it, this is what we call the lesser sac.
Yeah.
Right? Of course, if you had all the sequences, you would have picked it up. So this is a what? Pancreatic abscess. Right? This bubbly appearance. This is a complication of acute pancreatitis, and this is a pancreatic abscess of the lesser sac. Okay, this patient is similar, but which organ are you worried about?
So I'm worried about the bladder.
Okay, anything else comes to your mind?
So, bladder, the other thing could be the rectum.
Anything else? Okay, so the patient came from a maternity ward to, he was discharged from a maternity ward a few days ago.
So,
yes.
So it'd be the uterus, and it could be an infection secondary to retained products of conception?
Absolutely. So what we call the puerperal sepsis, of course, it's very difficult, but you have to stretch your imagination. What is happening? So this patient, of course, is status postpartum. So the uterus is still large, and with that, there is gas here. So she's very sick. Thank you. So next is candidate number 8. If you can raise your hand, please. Can you hear us, please?
Yeah.
Okay. Very easy fill, spot diagnosis.
So on this frontal chest radiograph of a skeletal mature patient, there's a large gas hollow viscous, which is occupying the right upper quadrant, starting from the right iliac fossa. It hasn't got any hostra within it. I can see some hostra, although on the left lateral side. So my diagnosis for this is likely to be volvulus, and I can't see any pneumoperitoneum. And
excellent, yeah. Excellent, well done. Conclusion.
So as this patient has got a volvulus, so I would relay the findings to the clinical team, and then.
Which kind of volvulus? I'm trying to hear which part of bowel you are talking about. Volvulus
Sigmoid volvulus.
Excellent. Okay, well done. I'll take over. So well done. So this is what we call the coffee bean sign. A coffee bean sign where you can see that this, volvulus of the sigmoid, actually this is an old film, but it gives you the concept in a much better way. What happens in sigmoid volvulus, that there is an inverted U appearance, and this coffee bean sign might not be visible in each and every case, so you have to see the concept. Ahostral margin. So this is the limb which is going superiorly, and this is the limb which is coming inferiorly. In between these two limbs is this white line, which is because of the opposing walls. And there are signs in old radiology literature, inverted U sign, ahostral margin, the apex under the left hemidiaphragm, apex superior to the level of T10, things like that. But this concept is, if you see, there is a sign in radiology, we call it inferior convergence. And I want you to remember it. If you stretch your imagination, this is the outer line, line 1. Number 2 is the line of opposing walls, number 2. And there is the third line, which is the line of this loop, which is descending down. Inferior convergence is that these 3 lines will converge to the point to the left side of the pelvis. This sign is known as inferior convergence. What I take home point is that the coffee bean sign looks very, a good word to use. But having said that, all cases will not be classical. This inferior convergence is a very nice sign to remember. So this was sigmoid volvulus and a barium examination of the same. There was no need, by the way. Okay, is this a sigmoid volvulus? What do you think? Or not? If not, then what else can it be?
So on again on this frontal abdominal radiograph, there is a dilated bowel loop, and I can see some hostra, incomplete hostra within it. It is on the left upper quadrant, and I can see gas within the small bowel. So if because of the location, I'm thinking that this could be cecal, but in cecal volvulus, it's the small bowel that is more dilated. So again, I think that this is a sigmoid volvulus.
Why have you changed your opinion from cecal to sigmoid? Just on the basis of small bowel? Okay.
Yeah, because I thought that in cecal volvulus, because if it's a twist in the cecum, then it should be the proximal, which is the small bowel, which should be dilated.
One of the principles of large bowel obstruction, you remember, large bowel obstruction can be with ileocecal valve, which is, not patent or patent. So small bowel is a tricky finding. You should never ever, make this opinion that I will look at the small bowel and then I will conclude. Your basic principles are the same. You have picked up that this thing has got hostile. Now, if you hostile, so this is not sigmoid. And please remember the basic concept. The patients who have got mesentery, the cecal mesentery, which is redundant mesentery, that will twist. So sometimes the cecal volvulus will sit in the left upper quadrant like this. That's a take home. But main point for you to remember is this hostile margin. On a contrast examination, what happens is that contrast comes here. And if you look carefully, this loop, there is no contrast. So there is a twist here. And again, you can see hostra. So this was a cecal volvulus. Okay, what do you think is happening here?
So there is a pneumatosis intestinalis because I can see air within the bowel wall. That's it. That's projected. No. It's the gallbladder. It's the right upper quadrant. So it's air within the gallbladder. Yeah.
So this is a emphysematous cholecystitis. What do you think is happening here?
So on this one, again, I can see some thumb printing because there is edematous bowel wall, and I can see that loop in the left iliac fossa, and I can see some dilated bowel loops that are in the pelvic region as well. Okay. And again, there is some air, yes, and then there is a triangular air in the region of the gallbladder.
Okay, so this is a bit of pneumobilia.
Is it Morris? Yeah.
So what's happening here?
Oh, so and there is a radiopeg density as well in the left iliac fossa, and yeah, so this is a gallstone ileus because it has got all three signs, which are small bowel loop dilatation, and then it's a calculus, and there is a pneumobilia as well. So it's a small bowel obstruction secondary to gallstone.
Excellent. This is an erect film, which just to develop the same thing, you see this string of bead sign, a string of pearl sign, dilated loops, and this is inside gallstone ileus. So we finish this, and thank you very much, candidate 8, and we are going to candidate 9. I will crack on for next 5-7 minutes, and then we will give you a break. So, okay, is it projected? No, sorry, I think I have not shared it correctly. So let me try it again. Screen share. Is it projected now?
No, yes.
Candidate 8, candidate 9 now. Can you raise your hand? Yeah, candidate 9 is with us, and over to you. Now, this case, I want all of you to concentrate. This is a very good teaching case, learning case. I want you to concentrate. And after this, I'll give you a 5-minute break, and I'll go into a bit of a teaching mode on this case also. So over to you, candidate 9.
So this is a, can you hear me?
Let me give you a hint that this is a story case. It tells you a story, and you will tell me what is the story. Over to you.
So this is a lateral projection of a barium contrast hollow. there's contrast outlining the hypopharynx and proximal esophagus, with some contrast seen with some contrast with some evidence of aspiration. There's impression of filling defect at the level of C2.
Don't worry about filling defect. So you have picked up some aspiration. What do you think is happening? Let me ask you, why has this examination been done? And this is, have you picked up the story?
Is this to check someone's swallow post-stroke?
Post what?
Stroke or...
Then why has this happened?
They haven't got a safe swallow and they've aspirated?
No, but this aspiration is not going anywhere into, let's say, the tracheobronchial tree. Actually, I have not shown you the AP. It is going out. It is going into the skin, actually. Do you see anything, any story written here on this? It's a post-surgical case. What kind of surgery has been done? No. Okay, fine, don't worry. The point is that it's a difficult case, but the but is it has come in the exam quite a few times. Sorry, I think you got muted. Were you saying anything, candidate 9?
Yeah, sorry, I was, yeah, I got muted. I was saying, is this, has it been some sort of esophagectomy or?
Excellent. So good thinking, and I will take over, right? All of you, if you can concentrate on this, because this is a very good teaching case. Part of it I will teach you in head and neck module, but let me tell you that this has happened so many times. This is a normal barium examination. Even last attempt, one of my students, the examiner asked all kind of anatomy on these views. What is this? What is this? What is this? Now, this is a post-total laryngectomy case. The case is actually post-total laryngectomy. So let me tell you the normal anatomy. Normal anatomy, this is an AP film of barium, and this is known as a veliculi here, and this one is right and left. This is the piriform sinus and the piriform sinus. On the lateral film, this is the veliculi, this is the hyoid bone, and this is the piriform sinus. The tongue impression is here, and the epiglottis is here. This is post-total laryngectomy. Complete anatomy is distorted, and you have to pick this up. You have to tell the examiner what has happened. Look at the hyoid bone, and the hyoid bone is missing. And look at this, it has become a featureless type of an inverted V smooth outline. We will come back to this when I go back to the basics. So let's go back and try to cover the anatomy. Now, we are interested in the anatomy of the pharynx. Please remember that if you draw a line through the hard palate here, and maybe the soft palate here, superior to that is the nasopharynx. We are not interested. Another line which you draw here through the superior border of the epiglottis, this is the oropharynx. Now, anything which is below that is known as the hypopharynx, also known as the laryngopharynx. In radiology, usually we use the word hypopharynx. Anatomists commonly use the word laryngopharynx. It's the same thing. Now, the hypopharynx is where the piriform sinuses are, and it is in continuity with the esophagus at the C6 level. and this is the cricoid cartilage, and this is the epiglottis. Take home point on this picture, this diagram, is midline hyoid bone. If you see the epiglottis, there is a fold of mucosa which is going from here to the tongue, and we call it glossoepiglottic fold. And within that is what we call the hyoepiglottic ligament. So there is a connection between the midline tongue and the hyoid bone and the epiglottis, and that actually forms this midline indentation here. This is that glossoepiglottic and the hyoepiglottic ligament together, right valliculi, left valliculi. So this is a very important point to remember. Now, on a plain film, if this is the hard palate, then superior to that is the nasopharynx. This is the hyoid bone, and this is the oropharynx, and inferior to that, this will be the hypopharynx. Cricoid cartilage is here. So on an MR, you can see the same thing, and just epiglottis. So this is the oropharynx, and this is the midline hyoid bone. This is the hypopharynx, and from C6 onwards, the esophagus is visible. Same thing on a CT scan. Oropharynx, and this thing is the laryngopharynx or the the hypopharynx, and the hyoid bone in the middle. Look at this picture, epiglottis, and this is that glossoepiglottic fold, and this is pre-epiglottic fold. And on an axial diagram, same thing here, epiglottis, and this is the glossoepiglottic. This space here is the valliculi, this is the valliculi. This is the piriform sinus, this is the piriform sinus. Take home point, valliculi are anteriorly placed, piriform sinus is posteriorly placed, and piriform sinus ultimately is in continuity with the esophagus. And this is how it projects on a lateral, and this is how it projects on an AP film. Anatomy of the larynx I'll teach you in the head and neck module. So look at this picture now, and now you can understand it's a featureless. Where is the valliculi? There is no valliculi. Where are the piriform sinus? There is nothing there. And where is the hyoid bone? It's missing. Take home point is that this is a status post total laryngectomy. We will learn this in the head and neck module, but when there is, invasion of, let's say, the cricoid cartilage, they have to do a total laryngectomy. There is a concept of partial, and there is a concept of total laryngectomy. So then you will get this featureless type of upper esophagus. And you have to tell the examiner that this is what is happening. Now, why do they ask this in your exam? Because these patients usually are old age patients, and they will also have radiotherapy. Because of post-radiotherapy, it's very common for them to develop fistula. And these are cutaneous fistulas, and that is why they will land up with you for contrast studies. This was a gastrographin, by the way. But similarly, you can do a barium also. And this is cutaneous. The fistula is visible. They just want to see the outline and track. So this is why this becomes a story film. Historically, now I'm going into a slightly different world. This is esophageal carcinoma. And historically, people have even pulled up small intestine. This is a historic film. I don't think so anybody does it now, because they will always, part of the stomach might still be there. But they have pulled up whole of the small bowel. But with that background, look at this. And this you have to remember for your exam. That the patient has got, some sort of esophagectomy has been done. And then a portion of the stomach, this is the new stomach. And radiologically speaking, there can be films in the exam which can come and have come. So I don't have any such example with me, but this is a very good example from StatDX. And I just wanted to show you, because in the exam tip, beware of post-surgical appearance. So I have shown you, total laryngectomy appearance. Beware of this, this esophagectomy. And similarly, in the stomach module, I will show you Billroth 1, Billroth 2, etc., which have come in the exam. They might show you a plain film like this, in which you will say, oh, there's a mediastinal mass and things like that. And there might be some stigmata or some evidence to show that this is post-esophagectomy. And you will be stretching your imagination, what can it be? And actually, it's simple, post-surgical. So this is exam tip to remember. Remember post-surgical appearances. This is a CT. Okay, we stop here, 5 minutes break, and when we come back, then we will